I'm Ronald Gagne, a member of the faculty for ICM, and we'll be teaching today the primary musculoskeletal examination.
Today we're going to be going over the primary musculoskeletal exam. Initially, we're going to have the patient standing, and you're going to ask them to walk to one end of the room. While doing so, please inspect the patient's feet, gait, and posture. Ask the patient to bend and touch their toes while noting any abnormalities in the spine. Ask the patient to bend as far back as possible while assisting the patient. You would also like the patient to extend, flex, and rotate their hips while noting any abnormalities. While in the seated position, we will now inspect the neck. Make sure to ask the patient if they feel any pain. You will begin by telling the patient to touch their chin to their chest and rotate in one direction, as fully as possible. The purpose for doing so is to allow the physician to check and inspect the neck of proper movement in all 6 axes. Now, while going behind the patient, make sure to palpate the cervical spinous processes. Be sure to note any tension or discomfort or any muscle spasms of the trapezius muscles. Be sure to check the passive range of motion of the neck. Make sure to ask the patient if they experience any discomfort. We will now begin with inspecting of the shoulder and upper extremities. Make sure to look out for symmetrical abnormalities, as well as active range of motion. You'll be instructing the patient to extend and flex their elbows and pronating and supinating their forearms, while also inspecting flexion and extension of the fingers. You will also be examining the rotation of the rotator cuff. Ask the patient to place their hand on the opposite shoulder and externally rotate and try to reach as far back as possible. Tell them to slowly turn their arms around and try to reach the opposite shoulder blade. In doing so, you can adequately assess abduction and adduction of their arms. Tell them to slowly turn their arms around and try to reach the opposite shoulder blade. In doing so, you can adequately assess abduction and adduction of their arms. We will now turn our attention to the palpation of the upper extremities. Be sure to pay close attention to the sternoclavicular, acromioclavicular, and glenohumeral joints. Also be sure to note the long head of the biceps and other insertion points of the muscles of the shoulder. While moving down from the shoulders to the elbows, be sure to palpate the epicondyles and olecranon processes. While holding on to the elbow, be sure to pronate and supinate the patient's arm in order to feel for any pain or discomfort. as you move from the elbow to the wrist, be sure to pay close attention to the radiocarpal and ulnar carpal joints, and be sure to palpate and inspect for any abnormalities. While performing the passive range of motion, be sure to place one hand on the patient's shoulder that you are moving. This is so that as you are moving the patient's arm, you can adequately feel and palpate the joints and muscles underneath. As you move down to the lower extremity, be sure to inspect the knee for any erythema, warmth, or any tenderness. When you palpate, be sure to palpate the tibial plateau, the tubercle, and patella. Be sure to also note any tenderness along the patellar tendons. When you're assessing the popliteal fossa, be sure to alleviate any pressure such that you are able to feel the pulse on the posterior side. As you continue to palpate to the ankle and foot, to be efficient, you will attempt to passively move the patient's foot and ankle in the plantar flexion mode, dorsiflexion mode, and try to invert and evert the ankle as well. You can also take this moment to assess the patient's muscle strength and tone of the lower extremities. You will learn this maneuver more in depth during your neurological examinations. With the patient lying supine, we will now be inspecting and performing passive range of motion movements of the knees and hips. We can turn our attention to the patella, and while placing our fingers over the patella, we gently palpate and apply a gentle downward pressure and rotating the patella in all four directions in order to feel for any crepitance. We will begin with placing one hand at the hip, specifically at the greater trochanter, and the other at the base of the foot, while performing a passive range of motion in order to demonstrate an internal and external rotation of the hip. We can then continue by doing what is known as a straight leg raise test, which will demonstrate the flexion of the hip. While the leg is in midair, you can now take the time to adduct and abduct the hip. While partially flexing the knee at 10 degrees, we can now test the integrity of the medial collateral and lateral collateral ligaments. With the knee flexed at 90 degrees, the examiner can now take the opportunity to test for the anterior and posterior cruciate ligaments. While flexing the hip at 90 degrees, we stabilize the femur with one hand and gently rotate the hip inwards and outwards to accurately assess a full range of motion, especially the internal and external rotation of the hip.
Internal rotation of the hip. Full flexion.
And finally, we can fully flex the hip and knee. That's it. While the patient chosen the prone position, you can place both hands to stabilize the pelvis and ask the patient to perform a full extension of the hip by telling them to raise one leg at a time. Take the time to palpate the paraspinous muscle groups working from the neck down to over the sacroiliac joint. Be sure to note for any spasms, pain, or tenderness. While using your 4 fingers, make sure to rotate over each spinous process, going from the top down. While doing so, be sure to ask the patient if they experience any pain, tenderness, or burning sensation. And thus concludes our examination.